Good morning, everyone. And this is the first seropositive inflammatory joint condition which we are going to study today called as rheumatoid arthritis. So, arthritis, it is very, very, very important in rheumatology. As I told you before, here in our place, they just gave three lectures of rheumatology, one for introduction, one lecture for rheumatoid arthritis, and one lecture for systemic lupus erythematosus. So, first of all, I would like to talk about um, what is seropositive inflammatory disorders, or how we classify the things in rheumatology. Now, you can see over here diagnosis versus classification in rheumatology. The diagnostic criteria are often dependent on disease progression and evolution over time, as early objective measures are often unavailable. And the classification criteria derive from studying patients with long term diseases and clear diagnosis in order to determine which criteria have good specificity in the early prediction of certain diagnosis. And now I told you this one is the first seropositive arthropathy. So what are seropositive arthropathies? It's simply in which we in their blood we found some serological markers like rheumatoid factor or ANA. A small subset of vasculites, a small like the small vessel anti-neutrophilic cytoplasmic antibodies associated vasculitides have a measurable serological component, but they are often considered a separate entity from seropositive disease by experts. So, we will discuss this one. What is vaginous granulomatosis, or what is Schwarz syndrome, or what is microangiopathic vasculitis. Talking about the introduction, rheumatoid arthritis is the most common inflammatory arthritis. It is present in almost all the population, though the incidence is less in Chinese and Africans. Generally speaking, 1% it affects around 1% of the population. And it's a chronic condition. It is characterized by persistent inflammatory synovium, which is covering the joint, which leads to cartilage damage, bone erosions, joint deformity, and disability. Now, um, so simply they have chronic, symmetric, erosive, or destruction of synovium. So what I'm saying, it is erosive synovitis of peripheral joints. Um, now, there is a diagnostic criteria for this thing. But before going to diagnostic criteria, of course, like when you will study the diagnostic criteria, you would understand the condition very much better. Okay, the female to male ratio is 3:1. Okay, the female to male ratio is 3:1. And not all, but many of the patients who get rheumatoid arthritis, they end up in permanent type of disability. So not all the patients they have the same thing, but many of them they do have um, disability, right? So this one can present at any age, but mostly, in the third to sixth decades, it affect mostly females, but it do affect the male as well. So this thing, of course, you understand once we'll start talking about the clinical features. In my previous lectures, I already talk about what is inflammatory, what is destructive or degenerative. So this is the inflammatory condition, and in this one, there is morning stiffness for more than 1 hour. 1 hour. Okay, talking about you can say the causes of rheumatoid arthritis, or you can say um, um, the etiology, right? So the etiology, guys, it's very, very poorly understood. Okay, they don't know much about the etiology. They have certain things on which they say that um, etiology. Okay, so there are some factors on the basis of which they say either the person have bad prognosis or good prognosis. But what they found until now is like both genetic and environmental uh, factors play some role. For example, if I will talk about the genetic one, let's make them separate by the way. If I will talk about the genetic one, guys, see, uh, what they found is um, you can say the people who are twins, they have higher chances of getting this condition when one of the twin is involved. Okay. On the other hand, they found that people who have rheumatoid arthritis, their first family member, they do have arthritis as well, rheumatoid arthritis as well. So that makes a very, very, very important thing. Like that's why they say that there is like the genetics or the genes play the role. Okay, now one of the thing which is very important, you can say MCQ question as well in PLAB and STEPS exams like this. They found like the people who have HLA-DR4 gene or region or human leukocyte antigen or MHC, uh, they are having increased chances of getting rheumatoid arthritis. So guys, remember one thing, rheumatoid arthritis is a autoimmune condition, right? Again, like it is not fully understood, but what they found, um, like people who have this thing, maybe there are some antibodies, which are formed against this or like against the body as well. So, and the people who are HLA-DR positive, by the way, whenever they get rheumatoid arthritis, their disease is severe than the other people. So this thing is very important, right? Um, now, of course, like there are many environmental factors as well which they play a role. Okay, and regarding the pathophysiology, of course, as we know, like this is uh, autoimmune condition. It causes destruction of the joints and things like this. So, but basically, you can say we can say simply it's an autoimmune disorder of unknown etiology, right? It is an autoimmune disorder of unknown etiology. So you can say like above this thing, the first major point will be what? Autoimmune disorder of unknown etiology, because simply what we are talking about is like what are the factors they found. But there are people who are HLA-DR4, but they don't have rheumatoid arthritis. There are patients like this as well. Okay, so this thing is very important. So HLA-DR4 as well as HLA-DR1 as well, right? So simply this thing is important. Okay, what they found: cigarette smoking increases the chances. Okay, cigarette smoking increases the chances. This thing is important, right? And again, they found a lot of processes, how the bones are destroyed. Uh, of course, like when there is bones are inflamed, or there is a bone repair mechanism also started taking up in response to inflammation. But what they found, like there is more destruction with less or either absence of bone repair. And there is elevated level of tumor necrosis factor TNF, uh, which increases the osteoclast. Clast are the bone. C for osteoclast comes with C. So C for osteoclast and C for bone cutting. So they are the one which cut the bone. And uh, B for building or osteoblasts are the bone building one. So what they found, like there is increased TNF factor, and they found like there is increased osteoclast but decreased osteoblast. Okay, so this thing is like they found. Now, of course, like some more things, what they found is, guys, remember, it is not the condition which only affect the joints, rather, it also affect the give systemic features as well. Very, very important thing. And simply, the patients who have rheumatoid arthritis, they have rheumatoid nodules in their hands, as well as it gives problems or lesions in the pleura, in the lung, in the sclera. Of course, when we will start talking about things, we'll talk about that. Uh, some of the things they found is you cannot say it's etiology, rather you will say that uh, poor prognosis is seen uh, with someone who have female gender. Okay, so female, and when metatarsophalangeal joints are involved. Okay, as well as smoking, positive rheumatoid factor, and anti CCP, right? Anti CCP, I told you it is the most specific one. So this is like these are the factors which are associated with poor prognosis. Now, simply, whenever there is the patient have rheumatoid arthritis, so we must talk about the clinical features, right? So now, see, you can see over here two clinical features: articular, which is involving the joint, and extra-articular, other than joints, right? So now I would like to talk about the articular manifestations first of all. A very nice diagram which is used to record joint disease activity. Uh, in rheumatology wards, you will find this thing on every chart with every history of the patient. And now you have to remember the basics, guys. See, it's an inflammatory type of disorders. They will present with morning stiffness for more than 1 hour. And the morning stiffness will become better when they will start moving. Okay. And now, one of the thing, guys, one thing which you must understand about this condition is it's a relapsing remitting condition. It's a chronic but relapsing remitting condition. What it means, there will be times when the disease will go into relapse and the person will be having joint pains, and there will be time when the disease will be under control. So it's a relapsing remitting but chronic type of condition. A typical presentation in these patients is basically pain and joint swelling, and the patients they complain of stiffness, mostly affecting the small joints of the hand, feet, and the wrist. But hands are most commonly involved. I'm not saying that it doesn't involve any large joints, but I'm saying small joints are more commonly involved. So right now we are just talking about articular features. So when we will go on to the extra articular features, we'll talk about them as well. Okay. Actually, how I teach rheumatoid arthritis is I take the students directly to this criteria because this one will best show you or tell you how the disease looks like. Now see this one. This is the classification criteria for rheumatoid arthritis. Total score of 6 or more classifies patient as definite rheumatoid arthritis. So, of course, like this is the things written. I will explain this chart in a very, very, very good way. And how many scores we need to say the patient have definite rheumatoid arthritis? 6. Patient must have at least one joint with definite clinical swelling, not better explained by another disease. For example, the patient maybe have one joint involvement, but it is due to septic infection or the septic arthritis. So, of course, like that cannot be taken in consideration. Uh, Now, you can see over here joint involvement swollen or tender. One large joint is involved shoulder, elbow, hips, knees, and ankles 0. 2 to 10 large joints, just 1 point. But 1 to 3 small joints, metacarpophalangeal, proximal interphalangeal, wrist, or second to fifth metatarsophalangeal joints, 2 points. But someone who have 4 to 10 small joints, 3 points, and someone who has more than 10 joints with at least one small joint, 5 points. Guys, how much we want? We want 6. And see, 4 to 10 small joints give you 3 points. When it comes to the blood testing, you will do serology, and if they have negative anti-CCP and negative rheumatoid factor, 0. Low positive rheumatoid factor or low positive anti-CCP, 2, but high positive RF or high positive anti-CCP, 3. So see, someone who have 4 to 10 joints are involved with positive anti-CCP and rheumatoid factor, or see, we need just one, not both. Done, the diagnosis is done. 3 plus 3 makes 6. Acute phase reactant, CRP, ESR raised, inflammatory process is going on, 1 point. Very important thing. Duration of symptoms less than 6 weeks, 0. More than 6 weeks or equal to 6 weeks, 1 point. So guys, do you think it is hard? I don't think this one is at hard at all. See how the patient present. The patient present with joint pain and swelling simply. If you can remember this, okay, you don't have to memorize it by heart, but this one is so easy that you can get a concept quickly. You can tell what kind of the condition, like maybe the patient have rheumatoid arthritis or not. So I don't find it difficult at all. So I'm just talking about the symptoms, guys. And this one is like the percentage, which joints are involved and how much percentage, okay? Not interested, by the way. So again, listen, not all the patients they present in the same way. How the patient of rheumatoid arthritis will present? Joint pain and swelling with morning stiffness, which is lasting for more than 1 hour. This will be the symptom. And when you are going to examine, now I will show you what to examine and what to see. So again, you can see a video of geeky medics, about hand examination, or simply you can. I have one, I think, examination video in diagnostics as well, and I think I did not. Maybe I talk about hand examination, or maybe I talk about shoulder examination. But in geeky, there is hand examination videos. You can watch that. Uh, it's not about only hand examination. Of course, we can examine the feet, we can examine the whatever the joints the patient is complaining, you can do that. Okay, so guys, we are still talking about uh, the articular features, right? So examination of the hand provides a very good reflection of the overall disease activity in these patients. And the typical features are basically joint involvement and symmetrical joint involvement. Involving which one? Remember, not DIPs, only MCPs and PIPs. But of course, we examine any joint how the patient presented. I already show you the diagnostic criteria. Now, the important thing here, when the patients, of course, they have rheumatoid arthritis in the start of the stage, what you can see over here, simply you cannot see much deformity. Rather, okay, there is deformity, of course. See, the PIPs are swollen and enlarged. There is no redness, and by the way, redness is not a feature. Okay, redness, remember, it's not the feature. So of course, like this patient have rheumatoid arthritis, and see there is swelling of the joints. And when the rheumatoid arthritis stays for a longer period of time, they have characteristics deformities over a period of many months or years, and they have different deformities. For example, one of the deformities is this one. You can see ulnar deviation of the fingers. Okay, ulnar deviation, because see the joints are destructive. It's a destructive type of condition, so that's why they destruct the joint. So this is due to the destruction of the MCPs, right? Then there is one more deformity called as C. These are the x-rays of the same patient. So see, ulnar drift is there, and you can see Z deformity of the thumb in this x-ray. The thumbs, they look like Z. Okay, this thumb, they look like Z. This is called as Z deformity of the thumb. Then there is button ear deformity. See, or there could be swan neck deformity. How we can define button ear deformity? See, there is hyperextension at the DIP and flexion at the PIP. How we define swan neck deformity? There is flexion at the DIP with hyperextension in the PIP. With flexion, you can say here, you can see the flexion at MCP. So this is how we define. See, like it's like you are pressing a button, and it's like a swan neck. And in this one, the thumbs look like Z. So this is Z deformity of thumb. This is button ear deformity. This is swan neck deformity, right? And these all show long standing disease. Of course, there are features in the foot as well. For example, there could be subluxation of the joints, a cock up toe, things like this, right? Flat foot, all the things can occur. You can see over here a button ear deformity. Okay, what is this one? Swan neck deformity. What is this one? Button ear deformity, right? Very easy. See how I know this is swan neck? Because there is what? This one. Flexion at the PIP. So this is how these patients they present in the joints. Now, guys, because like I will talk about all the articular features first, and then I will go on the extra articular features. This is the cock up toe deformity. You can see over here. Okay. Very, very, very important. There could be hammer toe, not visible over here. Okay, so these are all are present. Okay, these all can be present, not all the present. Like of course they can be present, and of course like when we examine the joint, we can found like some mechanical joint damage, like loss of motion, instability, deformity, crepitus. What is crepitus? When we move the joint, we hear the sounds. So all the things, we can found. We can found flexion contractures. We can found flexion contractors, contractures. Okay, guys. Other than this, you can see. Okay, this is rheumatoid nodule. I will show you later. Okay, one of the thing, guys, which we do is like this is the cock screw. Like they have, in the X-ray they are showing. One of the thing is atlantoaxial instability or C-spine instability. And of course, like when this thing occurs, it could be dangerous because it can lead to what? It can lead to neurological issues. Okay, so they may have atlantoaxial. They may have atlantoaxial subluxation. Like what is atlantoaxial? Like atlas and axis are the two bones, right? So that's why they are the one which is involved. So this is like atlantoaxial joint. There could be subluxation. It is a very common finding in long-standing rheumatoid arthritis. And why it occurs? Because there is a transverse ligament that is posterior in location. Okay, and that one is involved. So uh, that one is involved, and that's why whenever the patient they do flexion, okay, what happens is like there could be cord compression or sudden death in these patients, right? So here in the X-ray, maybe like it's not so clear. By the way, the X-ray quality is not good, but the odontoid peg is shown over here. Okay, so this thing, this thing is important, right? Atlantoaxial subluxation is important. So of course, like whenever there is atlantoaxial subluxation, guys, it can damage the spinal cord, which is very, very, very dangerous thing. So these things are there, and rest of the articular features, which can be there is many of the times, these patients they have limited shoulder uh, mobility. Okay, this is how they can be present. They may have tenosynovitis. What is tenosynovitis? Like inflammation of the tendons and the synovium. Many of these patients they may have carpal tunnel syndrome. And yes, very important thing is the knee, the synovium of the knee. What happens is like um, it can outpoach outside. We call it as Baker's cyst. We call it as what? Baker's cyst. And sometimes it can rupture as well. Okay, sometimes it can rupture as well. So extraarticular features, guys. It is not present in all of the patients, but it can present in many of the times. And they can present with anorexia, weight loss, fatigue, which are common. But most typical extraarticular features, which I will show you, starts from here. So constitutional symptoms, as I told you, they may have anorexia, fatigue, weight loss. Okay. Many of the patients, they have rheumatoid nodules. They may have rheumatoid nodules. And you can see this is a rheumatoid nodule. Okay, so this is, you can see the patient have rheumatoid nodule. So these nodules can occur in the patients, as well as there are other what you can say. Um, okay, and these one, they occur mostly in seropositive patients, and they usually occur at the sites of pressure or friction. So see, like this one is like in the extensor surface of the arm or forearm, right? So this thing is one of the thing, and then there could be hematological abnormalities like you can say they present with normocytic normochromic anemia, and I think like you must know by now because it's an anemia of chronic disease which most of the patients they have. Okay, now one very important question is called as Felty syndrome. So what is that? Like Felty syndrome is simply when someone has splenomegaly with neutropenia, we call it as Felty syndrome. And there is one more thing called as Kaplan syndrome. So when it will come along, I will show you. So Kaplan syndrome is very, very, very rare, but basically it is combination of rheumatoid arthritis. See this one. Someone who have rheumatoid arthritis, okay, with pneumoconiosis or lung involvement. And when we do a CT scan, we can found rheumatoid, like the nodules in their lungs, okay. We also call it as rheumatoid lung. You can see like all the x-rays they are showing. This one is of course like for pleural effusions they are showing. So pleural effusion are also common, but Kaplan syndrome, which is a rare syndrome, it is combination of rheumatoid arthritis with pneumoconiosis and you can say with intrapulmonary nodules. So Felty syndrome is splenomegaly with neutropenia. Okay, this could be one of the presentation in the patients. Okay, so this thing, this one, and other involvement or other features are, I told you, respiratory problems can be there, cardiac involvement can be there. So whenever it comes to the cardiac involvement, it can lead to pericarditis or pericardial infusion or cardiomyopathy. Most of the time, constrictive cardiomyopathy, but it is rare, not so common. Okay. Uh, in lungs, they can cause pulmonary fibrosis. Rheumatoid vasculitis now, um, or you can say the neurological things, which occur. Like one of the neurological thing I told you, there could be cervical cord compression, but one of the thing could be mononeuritis multiplex, in which like, see, vasculitis, it is going to inflame the vessels, and the vessels will be inflamed, which are supplying to the nerves. And what this thing will happen, that those nerves will be the one which will get destroyed, and like sorry, this arteries will, like these arterioles, you can say, will be the one which will get destroyed. And these arterioles which are supplying the nerve, they may have problem like this. So you can say that's how these patients they present with. So they may have carpal tunnel syndrome. They may have that cervical cord compression. They may have compression neuropathy is carpal tunnel syndrome. They may have mononeuritis multiplex, and they may have peripheral neuropathy. Okay, so any of these things can be there. So these are the neurological manifestations, or like this one is all I was talking about. And then the ocular manifestations, like ocular manifestation, guys, simply it present with uh, uh, the most common syndrome is called as keratoconjunctivitis sicca, and this is also known as uh, Sjogren syndrome, Sjogren, Sjogren syndrome. So what is this basically? What happens, like guys, um, their eyes, they cannot produce much tears. Why? Because their lacrimal glands are infiltrated with, you can say, the lymphocytes. Okay, the lymphocytes, they infiltrate the the glands, so they cannot produce enough tears. So simply due to that lymphocytic infiltration, they can it can lead to episcleritis or scleritis, like it present in this way. You can see like and this episcleritis is painless. Okay, so see this one, or scleritis, you can see this one due to vasculitis of secret scleral vessels, and this is like the corneal perforation in this patient, of course. So guys, remember, like rheumatoid arthritis is giving two type of features, vasculitic features and lymphocytic features. For example, I told you about mononeuritis multiplex or peripheral neuropathy. They are vasculitic features. And I told you about Sjogren syndrome, or which is also called as keratoconjunctivitis sicca. These are due to lymphocytic infiltration. Rheumatoid nodules are due to lymphocytic infiltration. Okay, and splenomegaly is due to lymphocytic infiltration. Amyloidosis can occur, which is again due to lymphocytic infiltration. Pulmonary fibrosis or pleural effusion can occur, it is due to lymphocytic infiltration. Okay, so this thing. So you can see like extraarticular manifestations, systemic, musculoskeletal, hematological, lymphatic, nodules, and ocular. Like of course, like they combine all of them in one place. Okay, here and more one. So these are the things which are due to vasculitis, and these are the cardiac extra articular manifestations. These are pulmonary, and these are neurological. But remember, it doesn't occur in all the patient. It occurs in some percentage of the patients. Okay, not all the patients. So keep this thing in mind. Okay. So these are the extra articular manifestations. Again, you can see, I will show you rheumatoid nodules, and this is also rheumatoid nodule. You can see, you can appreciate it very, very, very clearly, right? So this is how we see the clinical features of rheumatoid arthritis, right? So simply, um, Felty syndrome, Felty syndrome, by the way, I think if you remember, like Felty syndrome is splenomegaly with neutropenia, but that's enough for you. But Felty syndrome is more common in old age, like you can say in the people who are above 50. Uh, and they most of the time they are seropositive for rheumatoid factor, and they have splenomegaly on clinical examination. They have lymphadenopathy, they have weight loss, they have keratoconjunctivitis sicca, because as I told you, Felty syndrome is mostly due to lymphocytic infiltration. And when we do lab findings, we found anemia with neutropenia with thrombocytopenia. And you already had done hematology, so you know, like when there is neutropenia with anemia with thrombocytopenia, how the patient present, right? So this thing is very, very, very important. So uh, I hope so you understand the diagnostic criteria, which is very, very, very important. Okay, I hope so you know the clinical features. And now, of course, guys, not all the patients they present in the same way. Rather, there are patients who present in uh, pain, or like sometimes the patient produce with acute disease, which is quite severe. Some of the patients they have more relapses. Some of the patients they have less relapses. Okay, all these things factors play a role. So that's all about the clinical features, etiology, and introduction for rheumatoid arthritis. In the next lecture, we will talk about um, the lab diagnosis and the treatment for rheumatoid arthritis.